Ladies and gentlemen, dear colleagues, thank you for watching my presentation. Benign biliary disease has several causes. Most of them are traumatic, iatrogenic, or infectious, leading most probably to stenosis and or occlusions with or without lithiasis. The indications for percutaneous treatment of biliary strictures are high surgical risk patients, surgical failure, patients refusing surgery, and also cases where endoscopic procedure failed, intrahepatic strictures are found, or intrahepatic lithiasis is present. The contraindications are usually the primary sclerosing cholangitis strictures, lack of percutaneous access and ascites, and patients with advanced biliary cirrhosis. So far, the 3-year success rate following balloon dilatation of biliary strictures are quite good, reaching about 3/4 of all cases for stenosis following iatrogenic injuries. A little less, 67%, is the success rate for postoperative stenosis of biliodigestive anastomosis, and worst of all for sclerotic cholangitis, about 40%. The indications for percutaneous lithotripsy are failure of surgery or ERCP, as well as when biliodigestive anastomosis is previously performed. So, percutaneous cholangioscopy can help us in several cases, such as removal of calculus fragments, differentiation of non-lithiatic filling defects, and guidance of intraluminal biopsy. Of course, helpful is also in case of guidance for lithotripsy, either with electrohydraulic lithotripsy or with laser lithotripsy. Complications are rare, about 7% of the cases, mainly in form of biliary sepsis, hemophilia, and bile duct injuries. Here, a quite simple case of a biliodigestive anastomotic occlusion with filling defects above in form of stones. You see here, after percutaneous internal drainage, 2 oval-shaped stones above the occluded anastomosis. In such cases, we have to drain and then dilate the anastomosis until we have a good result, and then advance the stones through the anastomosis into the bowel. This is an optimal result of an easy case. But in many cases, we have problematic stones, which are endoscopically not accessible, or intrahepatically impacted, or quite large, or they are impacted above acute angulations of biliary ducts. The results of percutaneous lithotripsy are very high, as high as 100% in this paper from Korea. And the short-term morbidity is quite low. There is no mortality. Strictures reoccurrence remain a big problem. In about 38% in the next 17 months, we can have a reoccurrence of stenosis. So the success rate exclusive for patients with recurrent strictures are about 62%, and for secondary a success rate of 81%. The long-term morbidity rate is quite high and is mostly caused by reoccurrence of the stricture. In other papers, we see that the 7 years follow-up is also about 45% or 20 to 40% in 10 years. So restenosis remains a big problem. Here, a case of a very old male patient after laparoscopic cholecystectomy. We see here in MRCP that the papilla of Vater is inside a large diverticulum. This was the reason for ERCP failure. And there is also a stricture in the middle of common bile duct with some field defects above it. Cholangiography showed the stricture, and after internal drainage, here we can see the diverticulum and the catheter inside. So after internal drainage, we have to bring the patient back and perform percutaneous angioplasty. If the result is good, then we have no problems. But the stones we saw before above the stricture, they are now below the stricture and above the papilloflator. So we have to see them and catch them with a basket and retrieve them percutaneously through a sheath until we have a good result. But you see, after 1 month, we have no stones, but we might have a stricture. So in these cases, we can use special biodegradable stents, which might be very helpful after new dilatation and positioning of the stent. After 3 months, we might have this excellent result, and then we can retrieve the catheter. So this is a complicated case with a very good result, the percutaneous treatment. Now, because we said we might have about 40% of the cases reoccurrence, these cases I took the freedom and named them a chronic benign biliary disease, lithiasic origin. So we have in such patients, they might produce new stones. This is quite common, and recurrent lithiasis can occur many years later. Patients always come back to us because they were happy with our first treatment. So they come back to you because they want reintervention. So I will show you a couple of cases with chronic benign biliary disease. Here, first one, 42 years old male patient with cholangitis. He came to us September 2000. Before that, 3 years before that, he got cholecystectomy with CBD exploration. They left a T-tube inside for 18 months because they saw many stones inside. And then March 99, they retrieved the T-tube and placed an endoscopic plastic stent, which remained for another 18 months. So he came with to us with these images of intrahepatic impacted stones and cholangitis and jaundice. So PTC, September 2000, showed stenosis where the T-tube was, a migrated occluded plastic stent, and dilatation intrahepatically with many stones. So we chose, of course, to do a dilatation and lithotripsy. And as you see here, there are many stones impacted inside. Biliary tree was drained, plastic stent removed, structure was dilated, small stones removed, and intrahepatic impacted stones are still in place. So we performed in a percutaneous cholangioscopy and lithotripsy. We needed a second drainage for the large stone to get better access to that stone. So we have now 2 accesses. We removed all the stones after lithotripsy, and this is the result we had, many fragments, and the final result, December 2000. So the patient was very happy with that and came back almost 20 years later with new symptoms. July 2020, as a 62 years old patient he was, and he came back with symptoms since 3 months. The same images of impacted stones and also in ERCP, in MRCP, and cholangiography revealed intrahepatic dilatation, multiple stones, no stricture inside the liver, but papilla dysfunction with possible stenosis. So we decided to do again dilatation lithotripsy, but we started with a rendezvous procedure with sphincterotomy, removal of some stones endoscopically, and then internal drainage. Then August 2020, We did dilatation once again of the papilla and removal of the rest of the stones. This went very well. So December 2020, we had a very good result and the patient was happy and was released. Last case I would like to show you was 23 years ago, a 47 years old male patient with a TQ cholangiography after cholecystectomy without any findings. 3 months later, he came back with cholangitis and bilirubin elevation. And you see here the ERCP shows hilar strictures, probably because of a thermal injury. We drained, we had to dilate the stricture, and we had diffuse hemophilia, which got resolved. And then we left 2 parallel catheters for 6 months. The result after 6 months was not bad. Then we left closed catheter above the stricture, but 1 month later we had reocclusion. So at that time, we used to use metallic stents, and we did this in this case with the John Turco stent. We were happy, January 99. Patient went well, and he came back almost 8 years later with the same symptoms. Cholangiography showed occlusion of the stent. So we had to go through the stent, drain again, and do dilatations also to the left lobe, in this case, and this was the result. We were happy, yes, we were happy. Then 1 week later, we saw this image. It was a little stenosed, and what else can we do? There's something else. In this case was the cutting balloons. We used cutting balloons and we had that result. And we were really happy about that. Yes, August 2007, patient was released. Then he came back February 19 with the same symptoms. ERCP showed reocclusion, some filling defects in the right ducts, and we had to perform again percutaneous cholangiography. You see here the 6th duct is a segment duct is probably with some stones inside. We had to re-drain. It was quite difficult, and one option was to leave a permanent drainage catheter, but patient wanted to do more intervention, so we decided to dilate and do lithotripsy. So we did it in June 19, and this went quite well. You see here dilatations, stone retrieval, June 19, and everything was removed. And until we had this result, we were happy. Yes, everybody was happy, and until today, patient is symptom-free. Thank you very much for your attendance.